This question asks, what is the most likely diagnosis? And here we're seeing a round radiopacity in the maxillary sinus. So let's look at our answer choices. First, we have a surgical ciliated cyst. This would be a unilocular radiolucency at the site of previous trauma. Since this is not a radiolucency, this would not be the correct answer. Next, we have a myxoma. This would be a trabeculated, not well demarcated, and it would be rarely in the maxillary sinus, so we can eliminate a myxoma. Next, we have a dentigerous cyst. This would be a radiolucency associated with an unerupted tooth, and this would form around the crown, attaching at the CEJ. Since this is not associated with a tooth, we can eliminate this answer as well. Finally, we are left with an antral pseudocyst, which is a well-demarcated dome-shaped radiopacity on the sinus floor, which is exactly what we're seeing here in this panoramic radiograph, making option A the correct answer to this question. This question asks, what is the radiopaque finding in the edentulous area? So looking at our answer choices, we can first look at complex odontoma. This would be an irregularly shaped radiopacity with a radiolucent rim. This would also present as a mass of dental tissue, and that's not what we're seeing in this picture. Next, we have a cemento-ossifying fibroma. This would be a well-defined corticated radiolucency with variable degrees of internal calcification. This is strictly a radiopacity and does not present with any radiolucencies, so we can eliminate this answer as well. Next, we have normal anatomy. This is not normal anatomy, as we would not see these radiopacities in the normal anatomy of a patient's radiograph, so we can eliminate this answer as well. Finally, we have a foreign body, which in this case is an amalgam tattoo, and this is the correct answer to this question, making option B, foreign body, correct.
This question is asking each of the following is a likely clinical manifestation of Sturge-Weber syndrome except one. Which one is the exception? A seizure, vascular malformation, a port wine stain, or café au lait spots? Now this is a great question focusing on the Sturge-Weber syndrome, so let's start by talking about what it is. Now this is a vascular malformation anomaly, also known as encephalotrigeminal angiomatosis. This abnormality is congenital and it is not inherited and it's not a genetic problem. It is characterized by dermal capillary vascular malformations affecting superficial and deeper tissues in the region of cranial nerve 5. Neurological deficits associated with this condition can include seizures, intellectual disability, weakness or paralysis on one side of the body, migraines, growth hormone deficiency, and ocular involvement. The characteristic physical presentation of this condition is the port wine stain in the distribution of the first and sometimes second or third branch of the trigeminal nerve, which is why it's called encephalotrigeminal angiomatosis. This port wine stain is a red vascular malformation of the blood vessels and can be seen in the photo on the patient's left side. Radiographically, this syndrome is characterized by tram-line calcifications seen on the skull, which represent calcified walls of abnormal blood vessels. Treatment for this condition depends on severity and may involve medications, laser surgery, therapies, and even neurosurgery. Now, based off of everything we said for this condition, we know that the correct answer choice, or the answer choice that is not a likely clinical manifestation, would be D, these café au lait spots, and you can see one in the image. Now, café au lait spots are brown or tan flat areas of skin, and their name comes from the French phrase for coffee with milk. These hyperpigmented spots can vary in size and shape and are usually located on the torso, arms, and legs, but can be seen throughout the body. These spots themselves are asymptomatic, but they are associated with a handful of genetic conditions, including neurofibromatosis type 1 and McCune-Albright syndrome. Neurofibromatosis is a common hereditary condition that presents with a variable number of neurofibromas. Neurofibromas are unencapsulated benign tumors of neural fibroblast origin. They're seen on the skin most often, are soft, non-tender, well-demarcated lesions that are dome-shaped papules or nodules, and you can see some in the image below. Beyond just a number of neurofibromas and the café au lait spots, other symptoms include aggregates of dendritic melanocytes within the iris, freckling in the armpit area, and oral pigmentation and discoloration. In McCune-Albright syndrome, 2 or more bones are affected by fibrous dysplasia, café au lait cutaneous lesions are present, and the patient undergoes precocious or early puberty. Now, because these café au lait spots are associated with other genetic conditions and are not seen in Sturge-Weber syndrome, we knew that this answer choice was correct. Although we know that the other answer choices are likely clinical manifestations of Sturge-Weber syndrome already, let's briefly go over them again. We'll start with seizure. This is definitely a likely manifestation and is actually one of the most common and significant issues faced by patients with this condition. Seizures are especially common during infancy and early childhood for these patients, and they're due to abnormal blood vessels in the protective layers surrounding the brain. Because this is definitely one of the neurological symptoms observed in this condition, we knew that this answer choice was incorrect. Next, we have vascular malformation. Now, this answer choice was definitely incorrect because this entire neurological disorder is based around these vascular malformations. Vascular malformations just refer to abnormal formation of blood vessels, particularly in the brain and skin for this condition. These malformations are present at birth and are a central feature to this Sturge-Weber syndrome. They cause other symptoms as well, such as the seizures and port wine stain. Because this is definitely one of the clinical manifestations of this condition, we knew that this answer choice was incorrect. And finally, we have this port wine stain. And once again, another very characteristic symptom of this condition, and you can see it again on the patient's left in the picture. As I said earlier, this characteristic birthmark follows the distribution of the first and sometimes second or third branch of the trigeminal nerve and is a red vascular malformation of the blood vessels. This port wine stain is a hallmark feature for this condition, so we knew that this answer choice was also incorrect. So when discussing Sturge-Weber syndrome, the likely clinical manifestations would be seizures, vascular malformations, and a port wine stain. Café au lait spots are not a likely clinical manifestation for Sturge-Weber syndrome and are instead seen in the conditions such as neurofibromatosis and McCune-Albright syndrome. It is not inherited and it's not We have a male, he's 48 years old, and he says, I think I have some cavities. He has acid reflux, he's a 25-pack-year smoker, and he's taking omeprazole. We notice a diffuse whitening of the posterior hard palate with a cracked appearance and crater-like red points, and we're asked, what is the most likely etiology of this condition? Now, before we can decide on the etiology of this condition, we obviously need to decide what condition the patient even has. The most helpful piece of information obviously given to us is the description of this lesion as a diffuse whitening of the posterior hard palate with a cracked appearance and crater-like red points. This description provides the specific location of this lesion, which is helpful because the correct diagnosis is only seen on the posterior hard palate. Also, its description as a cracked appearance with these crater-like red points is very characteristic, and it's practically buzzwords for this specific condition. One other hint is given to us in the patient box, and that's the fact that this patient is a 25-pack-year smoker. The correct diagnosis is due to this smoking habit, so this information really allows us to make that diagnosis and to know the etiology. And based on this description and the patient history, we know that the patient has nicotine stomatitis, and we can see that in this image. Before we discuss the exact etiology, let's discuss what this condition is. Now, nicotine stomatitis is also known as nicotinic stomatitis, and it's a diffuse white appearance to the posterior palatal mucosa, causing the surface to be wrinkly, fissured, or cracked. This is characterized by elevated papules with punctate red centers, which are those crater-like red points mentioned in the patient box. These red centers represent inflamed minor salivary gland orifices. Now, back to the question being asked, what is the etiology of this condition? This condition is associated with smoking, especially those who smoke pipes and cigars, but it is not due to the nicotine, but is instead due to the heat generated when smoking, making the correct answer choice C, heat from combustion of tobacco products. The name is very misleading, but it's not due to the chemicals or nicotine in tobacco smoke, but is instead an inflammation of the salivary glands in response to heat. We know this because this condition can also be present in people who chronically drink very hot beverages, such as coffee or tea. There's typically no treatment for nicotine stomatitis, and the clinical appearance will go away in 1 to 2 weeks if the patient stops smoking or consuming those hot beverages. Now, although this is definitely the correct answer, let's go through the other answer choices and discuss what conditions they can cause and why they're incorrect. I will start with infection by group A streptococcus. Now, group A streptococcus is the specific group of bacteria that is known to cause streptococcal pharyngitis or strep throat. Now, I'm sure you're familiar with strep throat, but we'll talk a little bit about this bacterial infection that's known to cause this sore and scratchy throat. This infection is most common in children, but can affect any age, and if untreated, can cause complications that include rheumatic fever. It is spread through droplets or shared food and drink, and it's treated with antibiotics. Clinical signs of this condition are throat pain, painful swallowing, swollen and red tonsils, headache, fever, nausea or vomiting, body aches, and palatal petechiae, which are these small red spots on the palate that you can see in the image. Now, why is this answer choice incorrect? Although this bacterial infection can present somewhat similarly with these palatal petechiae, this is a systemic infection that is not just due to a smoking habit. This would likely have a number of other symptoms, such as that sore throat that hurts when swallowing or a fever. We were not given any other information about any of these symptoms in the patient box. This could also definitely be tested. A strep test can be administered to see if the person has strep, and then the infection would be treated accordingly. Because this patient is asymptomatic and instead has a 25-pack-year smoking history, they're presenting with nicotine stomatitis, which is a response to heat in tobacco products and not due to a group A strep infection. Next, we have nicotine in tobacco products. Now, this was definitely the tricky answer because the name of nicotine stomatitis is so misleading, but we already talked about why this is incorrect. Obviously, the nicotine and other components of cigarettes have a number of negative effects on the body, but they do not cause nicotine stomatitis, which means that this answer choice is incorrect. To say it again, we know this is not the etiology because the same presentation is seen in patients who chronically drink hot beverages, proving that it's due to heat and not due to nicotine. And finally, we have ill-fitting dentures. Now, ill-fitting dentures can cause a number of problems for patients beyond just being uncomfortable and lacking in function. One thing that ill-fitting dentures are known to cause is inflammatory papillary hyperplasia, which is technically these fibrous, benign, mesenchymal tumors that present on the palate. They're very small. This condition is also known as denture papillomatosis, and it may have superficial candidiasis overlaying it. Now, clinically, it presents as numerous asymptomatic erythematous papules on the central region of the hard palatal mucosa, and you can see that in this image. This condition is also associated with poor denture hygiene and wearing a denture 24/7, so someone who never takes it out. Now, this is treated by removing the denture to allow the erythema and edema to subside, and then excising the hyperplastic tissue before fabricating a new denture. Now, although this condition can present similarly, this answer choice is incorrect for a number of reasons. First of all, we were given absolutely no indication that this patient even wears a denture. It would need to be indicated to us that he wears some kind of prosthesis for us to assume that he has inflammatory papillary hyperplasia due to an ill-fitting denture. This also presents as raised fibrous lesions on the center of the palate that will not have the characteristic red centers and cracked appearance that we saw in nicotine stomatitis. This would also not disappear if the patient was able to stop smoking, but would have to be surgically removed. Because nicotine stomatitis is not due to an ill-fitting denture, and our patient doesn't even wear a denture, this answer choice is definitely incorrect. So when you have a patient with a smoking habit who presents with this diffuse palatal whiteness, a cracked appearance of the palate, and crater-like red points, you should always diagnose it as nicotine stomatitis. And although the name is misleading, make sure to keep it straight that this is due to the heat from combustion of the tobacco products and is not due to the nicotine itself. In this question here, we have a patient that presents with multiple myeloma. So we're to take a look at the 4 options here and see which appearance would occur in a panoramic radiograph for this patient. If we take a look at the med history to the left, we can see that the patient has a chief complaint of falling and breaking his jaw, and this just means that we can expect to see signs of mandibular fracture in the panoramic radiograph. So the correct answer here is A, which is multiple well-defined radiolucent lesions. Multiple myeloma is a malignant proliferation of plasma cells, and it can affect bone anywhere in the body, as we can see here, but the jaws are affected around 30% of the time. It is a fairly destructive disease, which is why we can see all these radiolucencies, and these just represent the bony lesions that are occurring. And these are found more frequently in the mandible compared to the maxilla. However, just the presence of these lesions is not unique to multiple myeloma, so further testing is required to make a diagnosis. I'll just take a look at the other options now, and we can see why they do not represent multiple myeloma in a panoramic radiograph. So next up, we have ground glass appearing radio-opaque lesions. And these are not seen in multiple myeloma. However, they are indicative of fibrous dysplasia, so this option is also incorrect. These lesions will be poorly defined and are due to the replacement of normal bone by immature bone and fibrous stroma. What's interesting is that they can occur with pathological fracture, which is why it was important to know that the patient did have that fall, so we know that it was due to that and not due to fibrous dysplasia. Next up, we have a cotton wool appearing radio-opaque lesion, and if we see this, we can also rule out multiple myeloma because this is a common feature of Paget's disease. And in Paget's disease, there is a remodeling of the trabecular bone, which makes it look disorganized and sclerotic. So we can see an example of it here in the skull, and it looks kind of fluffy like cotton or wool. And patients who have this will also likely present with increased serum alkaline phosphatase levels. Next up, we have multiple supernumerary teeth, which is usually associated with syndromes or genetic predispositions, whereas multiple myeloma is a destructive disease of the bone. So we can commonly find supernumerary teeth in those with Gardner syndrome, in which case we can also look out for osteomas and dentigerous cysts. We can also see supernumerary teeth in those with clinocranial dysplasia, but what's interesting is that people with clinocranial dysplasia can also present with a reduced number of teeth. They can also present with abnormal roots or crowns, or a cleft palate and an extremely narrow arch. So now we know what to expect in a patient with multiple myeloma. This question is asking, what is the transmission of hepatitis A? Sexual, parenteral, blood, perinatal, or fecal-oral? Now this is a good, straightforward question testing your knowledge of hepatitis A. We hear a lot about hepatitis B in the dental world, but it's important to know about the other types of hepatitis for the board's exams as well. Hepatitis A specifically is a benign, self-limited infection due to an RNA virus with transient viremia. This type of hepatitis is not a chronic disease, and the incubation period for the disease is 2 to 6 weeks. Not everyone infected with hepatitis A exhibits symptoms, but common symptoms include dark urine, diarrhea, fatigue, fever, nausea, and jaundice. There's also a safe and effective vaccine available for this condition that is recommended to be taken. Now, as far as the method of transmission, hepatitis A is commonly seen in overcrowded or unsanitary conditions, and people often get it from the ingestion of contaminated water and food. food, meaning that the correct answer here would be D, fecal oral. Now, this is the correct route of transmission for this form of hepatitis, but this is not true for all forms, as we'll talk more about as we go through the other answer choices. The reason that hepatitis A is spread via the fecal oral route is because the virus lacks an envelope and is not destroyed in the gut, which is true of hepatitis E as well, but is not true of other forms of hepatitis. So let's go through these other answer choices, and we'll start with sexual. Now, this answer choice is incorrect because hepatitis A is not sexually transmitted. Other forms of hepatitis, including hepatitis B, hepatitis C, and hepatitis D, are sexually transmitted alongside other STDs like HIV, HPV, and syphilis. But because sexual contact with a hepatitis A patient will not cause an infection, we know this answer choice is incorrect. Next, we have parenteral, or blood. Now, parenteral refers to administration or transmission of something that does not occur via the alimentary canal, which is the entire route that food would take from mouth to anus. Now, this word is commonly used to describe medications that are given intravenously or subcutaneously, but when discussing a route of transmission for a disease, it refers to the spreading of a condition by blood. Now, this route describes all these blood-borne pathogens that we learn so much about in dentistry and do our best to avoid with proper needle safety and sterilization. Now, conditions that spread via this route of transmission include hepatitis B, hepatitis C, and HIV, but not hepatitis A, making this answer choice also incorrect. And then we have perinatal. Now, the perinatal route of transmission refers to a mother passing a disease to her baby during pregnancy. And certain conditions such as hepatitis B and C, HIV, and herpes simplex can all be spread from a mother to her baby in the womb because the mother and the baby are sharing blood. But hepatitis A cannot, making this answer choice also incorrect. So we know that when discussing hepatitis A, it is spread via the fecal oral route. But I want to emphasize again that this is not true of most forms of hepatitis, with the only other form of hepatitis spread via this route being hepatitis E. And you can see all this in this chart on this slide. Hepatitis B, C, and D are all spread via the parenteral, sexual, and perinatal routes instead, and are also more chronic conditions, while hepatitis A was self-limiting. It does not last for a long time, and it'll only give symptoms for a little bit and will be self-limiting. It will go away, while these other forms of hepatitis that are spread via these other routes are chronic. They will cause problems for a very long time. We have a 57-year-old female who says, I'm here for my cleaning. She has gastroesophageal reflux disease, asthma, she's a social drinker, and she has a 30-pack per year of smoking history. She's taking some medications, she has a coated tongue, halitosis, which is just bad breath, and a leukoplakia of the right buccal mucosa. And we're asked, each of the following is a major risk factor for squamous cell carcinoma of the oral cavity, except one. Which one is the exception? So this is a pretty straightforward question where we actually don't need the patient box at all to answer it, but it does present us with a good patient example of some of these risk factors. Before we can discuss what the risk factors for oral squamous cell carcinoma are, let's first talk about oral squamous cell carcinoma as a whole. And I've attached an image of how a leukoplakia might present, just like she has a leukoplakia on her right buccal mucosa. Here's an example of that premalignant lesion on her tongue. Now, this condition, oral squamous cell carcinoma, is the most common oral malignancy, making up around 90% of all oral malignancies, as well as 2 to 3% of all cancers in the US. The etiology for oral squamous cell carcinoma is multifactorial, and there are both extrinsic and intrinsic risk factors associated with the condition. We'll come back to the extrinsic risk factors later, since that's what the question is asking about, but the intrinsic risk factors include being a male over 50, being malnourished, and being immunocompromised. The most common sites for this condition are the tongue, especially the posterior ventrolateral area, and the floor of the mouth, often near the midline. Clinically, they present as firm, rubbery, or indurated. They are often ulcerated, and their color can range from normal to white to red, which would be leukoplakia to erythroleukoplakia to erythroplakia. Pain is often a later symptom, and these lesions are well known for mimicking many other oral conditions. Treatment for this malignancy includes wide surgical excision, radiation therapy, and chemotherapy, and the prognosis depends on the stage, but is unfortunately generally poor. Now back to the question being asked, those extrinsic risk factors for oral squamous cell carcinoma. Some of these answer choices you probably knew right away, but others may have been a little bit tricky. This is also most likely a question that you answer based off of elimination. You may not have known that one of these was not associated with this malignancy, but you should have definitely known that the other three were associated with it. And the answer choice that is not a major risk factor for squamous cell carcinoma would be C, marijuana use. Marijuana use can certainly have other side effects such as paranoia or anxiety, but it does not increase the risk for a patient to develop squamous cell carcinoma. This obviously means that tobacco use, alcohol consumption, and chewing betel quid all are major risk factors for this malignancy, so let's talk a little bit more about them in depth. We'll start with tobacco use. Now, this is a major risk factor for oral squamous cell carcinoma among other malignancies, especially when it comes to smoking cigarettes. 80% of patients diagnosed with oral squamous cell carcinoma have a history of tobacco usage. But the good news is that after 10 years of habit cessation, you haven't been smoking for 10 years, the risk for a patient decreases to around the same risk level for a non-smoker. Other forms of tobacco, such as chewing tobacco, are also extrinsic risk factors for this malignancy, making this answer choice obviously incorrect. Next, we have alcohol consumption. Now, alcohol consumption has also been determined to be a major risk factor for oral squamous cell carcinoma, especially when it is done in combination with tobacco use. The risk greatly increases when these two risk factors are combined. And because this is definitely a risk factor, either combined or on its own, this answer choice is incorrect. And finally, we have chewing betel quid. Now, this is the only answer choice that you may have been a little bit uncertain about, but hopefully you've heard about and learned about betel quid at some point. These betel leaves are combined with nuts and slaked lime and are chewed for their stimulant and narcotic effects in a number of Asian and oceanic countries. This habit is associated with a condition known as oral submucous fibrosis, and is definitely a major risk factor for oral squamous cell carcinoma as well, making this answer choice incorrect. So it's definitely important to know that the major extrinsic risk factors for oral squamous cell carcinoma are tobacco use, alcohol consumption, and chewing betel quid, while marijuana usage is not a major risk factor. We have a 3-year-old male who has elevated thyroid-stimulating hormone levels, low T4 levels, and lower than normal stature, and he also has bilateral swelling of the face, which you can see a similar bilateral swelling in this image. We're being asked which is the most likely cause of this presentation: Down syndrome, cretinism, myxedema, or thyrotoxicosis. Now, this question may have been a bit tricky because some of these answer choices are pretty similar, but let's just start by looking at the important clues given to us in the patient box. The most important piece of information given is in reference to these thyroid hormones. We're told that the patient has elevated thyroid-stimulating hormone and low levels of T4 or thyroxine. Now, thyroxine is the primary hormone produced by the thyroid gland, and it's mainly responsible for regulating the metabolism and playing a role in growth and development. If levels of this hormone are low, that indicates decreased thyroid function, which would explain why the TSH levels are elevated. The elevated TSH level is a compensatory response from the pituitary gland, which detects low thyroid hormone levels and tries to stimulate the thyroid to produce more by releasing more thyroid-stimulating hormone. But it obviously isn't working in this case. This improperly functioning thyroid is leading to these other symptoms noted, such as the lower than normal stature and the bilateral swelling of the face. So now we know the patient has a deficient thyroid, but another important clue is the patient's age. The fact that he's only 3 years old is such an important piece of information when answering this question, because impaired thyroid function in a patient of this age would only indicate B, cretinism. Now, cretinism is a severe form of congenital hypothyroidism, meaning that the affected patient is born with some kind of thyroid hormone defect. This condition leads to profound mental and physical delays due to those thyroid hormone roles in growth and metabolism that we spoke of earlier. Without sufficient thyroid hormone, critical processes such as brain development and physical growth are severely affected, leading to irreversible mental retardation, stunted growth, which is that lower than normal stature, and physical deformities. Other symptoms include lethargy, low muscle tone, jaundice, a protruding tongue, bilateral swelling of the face due to fluid retention, constipation, and cold intolerance, which are also just common signs of hypothyroidism in general. Causes of cretinism include absence or malformation of the thyroid gland, genetic enzyme defects in the thyroid, iodine deficiency, or certain syndromes. The good thing is that early diagnosis and treatment can help prevent the severe developmental and physical consequences that come alongside the condition. If cretinism goes untreated, though, the effects are severe and irreversible. So because we're seeing these decreased thyroid hormone levels in a child of this age, we knew that he is presenting with cretinism. Let's still go through the other answer choices and talk about what each one is and why they're incorrect for this patient. I'll start with Down syndrome, which you've definitely heard of. It's also known as trisomy 21, and in babies with this condition, they have inherited an additional chromosome at position 21 instead of just the pair that is typically seen. The syndrome is seen in 1 out of every 691 births, and the risk for this syndrome increases as the age of the mother increases as well. Symptoms of this condition include a flattened face, almond-shaped eyes that slant upwards, a protruded tongue, a short neck, mild to moderate intellectual disabilities, musculoskeletal and movement problems, congenital heart disease, and shorter than average height. Dental-specific problems associated with the condition include delayed eruption of both dentitions, hypodontia, microdontia, macroglossia, a protruded tongue, malocclusion due to a small maxilla, and an increased risk for periodontal disease. Treatment for this condition involves a multidisciplinary team and is based on each individual's physical and intellectual needs. Now, we knew this was not the correct answer choice because the patient was not presenting with any of the characteristic features of Down syndrome. Although patients with Down syndrome may also have intellectual disabilities and short stature, this is due to their syndrome and not to a reduced level of thyroid hormone levels. Cretinism can be reversed or treated if caught early, while obviously Down syndrome cannot. Karyotyping, or looking at a map of the chromosomes, can also be done to prove that a patient has Down syndrome, so we knew that was not the case here. So because these two diagnoses present very differently, we knew that this answer choice was incorrect. Next, we have myxedema. Now, this answer choice may have been really tricky if you didn't know the difference between myxedema and cretinism, but knew that both were associated with hypothyroidism. The very important distinction is that cretinism is congenital, meaning it affects infants and children, while myxedema affects adults. Cretinism is congenital hypothyroidism, usually due to an improperly developed or absent thyroid, while myxedema is severe hypothyroidism in adults that has gone untreated for an extended period of time and is often due to things like an autoimmune condition attacking the thyroid. So myxedema specifically refers to severe manifestations of hypothyroidism and is characterized by swelling of the skin, physical and mental sluggishness, and extreme cold intolerance. It can be due to autoimmune diseases, like I said, such as Hashimoto's thyroiditis, but can also be due to certain medications, surgical removal of the thyroid, ablation of the thyroid, or an iodine deficiency. If this goes untreated, it can lead to a myxedema coma, which is a life-threatening emergency typically triggered by a stressor such as infection, cold, or trauma. So although this is also a form of hypothyroidism, we knew that this was not the correct answer choice because it is seen in adults and our patient is only 3. Myxedema would also not cause lower than normal stature because it does not impact growth or development, even if it may cause peripheral swelling. So because this is a different manifestation of hypothyroidism, we knew that this answer choice was incorrect. And finally, we have thyrotoxicosis. Now, this answer choice may also have been kind of tricky if you didn't know what thyrotoxicosis was, but knew that it was associated with the thyroid. This answer choice is basically the opposite of what we're seeing in our patient. In this condition, we see an excess of the thyroid hormones in the bloodstream. Thyrotoxicosis can be due to internal hyperthyroidism causes, such as Graves' disease or an adenoma, but it can also be due to exogenous sources, such as an overuse of a thyroid hormone replacement. Symptoms of this condition include tachycardia, weight loss, excessive sweating, heat intolerance, tremors, irritability, mood swings, and many of the other symptoms you associate with hyperthyroidism. I do want to stress that this is not technically the same thing as hyperthyroidism, even if they're sometimes used interchangeably. Thyrotoxicosis just explicitly refers to the increased thyroid hormones in the bloodstream, while hyperthyroidism is when the thyroid gland itself is producing excess thyroid hormone. So thyrotoxicosis can be due to exogenous sources as well, like taking excess thyroid hormone replacements. Either way, we knew that this answer choice was incorrect because this is characterized by the exact opposite of what our patient is experiencing. Our patient has decreased hormone levels instead of increased and is not experiencing any tachycardia or heat intolerance or any other symptoms seen in thyrotoxicosis. We also would not see lower than normal stature, making this answer choice incorrect. So we know that when a 3-year-old patient presents with elevated TSH, low T4, and lower than normal stature, that they have cretinism and not Down syndrome, myxedema, or thyrotoxicosis. This question is asking, what is a mass of excess normal tissue found in an abnormal location? A hamartoma, a teratoma, a choristoma, or a blastoma? Now this is another pretty straightforward question that could just be easy points for you on the boards if you know it. We're given an exact definition and need to know which of these it belongs to. Now I also want to point out that all of these answer choices end in oma, which is just a suffix that means a growth or a tumor. And in this case, the correct answer, the correct tumor growth that matches the definition, would be C, a choristoma. Now, as the question says, this is a benign collection or mass of histologically normal tissue that is not normally found in that anatomical site. Now, another way to phrase this is that a choristoma is a tumor-like growth that has developed from groups of primordial cells located at a site remote from the original tissue or organ. Now, an example of this is the osseous choristoma, which would present as a bony lesion in an area that does not normally have bony tissue, such as the tongue. Now, although this is the correct answer choice, let's go through the other growths and discuss what the definition would be for each of those. We'll start with the hamartoma. Now, this is basically the opposite of the choristoma. A hamartoma is a benign proliferation of disorganized tissue normally found at the site. So instead of being histologically normal tissue, as we saw in the choristoma, we are seeing abnormal tissue. And instead of the tissue being found in an abnormal location, we're finding it in a location it is normally in. So complete opposites, basically. So for example, if a hamartoma was found on the skin, it would be made of cell types and tissue types typically found on the skin, but would present disorganized or abnormally. The polyps seen in Peutz-Jeghers syndrome are another great example of hamartomas, which is what we're looking at in this image. These are relatively common, definitely more common than choristomas, which makes sense because the cells are found in their normal location, and typically have minimum growth potential. The most common site for hamartomas to be found is actually the lungs, but they can be seen throughout the body. Next, we have a teratoma. Now, this is typically a benign neoplasm derived from more than one germ layer. This means it contains cells or tissues from at least two of the endoderm, mesoderm, or ectoderm layers. These cells may be well differentiated or incompletely differentiated, and these can become malignant, especially when they're incompletely differentiated. Now, some of the most common structures found within a teratoma are hair, fat, muscle, and even teeth. More complex body parts like liver, lung, and even brain tissue can be seen in teratomas, but not as commonly. The dermoid cyst is an example of this lesion, but the most common teratomas are ovarian and testicular teratomas. And last, we have a blastoma. Now, this might sound familiar to you. This is a malignant neoplasm of precursor cells which are known as blasts. Examples of blasts you may be familiar with are osteoblasts, odontoblasts, cementoblasts, and many more. These precursor or stem cells give rise to the specialized cells we see throughout the body. Blastomas are given more specific names depending on the exact blast cells being affected. So an example would be a retinoblastoma that affects the precursor cells of the eyes. That's what retino means. Now, because these affect precursor cells, these types of tumors are unfortunately more often seen in children and usually present before the age of 5. Examples that we see in the dental office include the ameloblastoma and a cementoblastoma, which is exactly what we're seeing in this image. This is a cementoblastoma. So we see these in the dental office quite a lot. But when we're given the definition of an excess of normal tissue found in an abnormal location, we always want to know that what we're talking about is a choristoma.
Which of the following pathologies is the most likely diagnosis for this patient? So this patient is a 22-year-old female who presents with pain. And then upon clinical examination, we do see a radial opacity at the apex of the lower left first premolar. And in this region, we'll also see caries and pulpal inflammation. So given this information, due to irritation and inflammation, and we know that the patient does have pulpal inflammation and caries on this tooth. Radiographically, we'll also see a loss of lamidura and a widened PDL space. Since the patient is experiencing pain, treatment would be a root canal treatment or an extraction. But if the patient was not experiencing any pain, then no treatment would be needed. So we'll take a look at the other options to determine why they are incorrect. First, we have idiopathic osteosclerosis, which is also known as a dense bone island. And while it does appear as a radio-opaque region, it's generally not associated with inflammation or irritation. But we know that the patient is experiencing this, so this is incorrect. It'll also appear as asymptomatic, so it shouldn't present with any symptoms, and it'll likely show up as an incidental finding on a radiograph. Next, we have cementoblastoma, which does occur in younger patients, and we know that the patient is 22 years old. It does affect the mandibular molars or premolars, and it can be associated with pain and tooth mobility, but it's generally asymptomatic. Cementoblastomas will also be radio-opaque because excess cementum is found forming around the roots of the teeth, but we know that a cementoblastoma is not what's represented in this patient because it will present with a radiolucent rim surrounding the radial opacity. So we know that this pathology is incorrect. Radiographically, we might also be able to see resorption and enlargement sometimes. Finally, we have an ameloblastoma, which is found in the posterior mandible and molar region, and it's asymptomatic, but it can sometimes present with swelling and asymmetry. We know that this answer is incorrect because it will appear radiolucent, and it might have a soap bubble-like appearance due to radio-opaque septa that are found throughout. So now we know what all these pathologies look like on a radiograph.
We have a 58-year-old female who says, my gums have been progressively getting more painful when I eat spicy food. She has a 2-pack year smoking history, she has hypertension, she's taking Lasix, her blood pressure is a little bit high, and she has generalized gingival erythema and small ruptured gingival blisters. And we're asked, which is a possible area of spread for this patient's condition? Now, before we talk about what's a possible area of spread, we need to know what this condition is. Let's go ahead and look at this patient box. And one of the big clues that we're given is this generalized gingival erythema. The fact that it's generalized is a clue in itself because it indicates that this is a generalized condition and it's not just a local irritation that we're seeing. Only a limited amount of conditions would cause diffuse redness of the gingiva. Another big clue that we're given is these small ruptured gingival blisters. The presence of blisters is another big clue that points us toward a blistering condition. And in this case, the correct answer here is mucous membrane pemphigoid. So that's the diagnosis that we're seeing for this patient and will allow us to answer the possible area of spread. Now, mucous membrane pemphigoid is an immune-mediated mucocutaneous blistering condition. It's called pemphigoid because it's similar to another blistering condition known as pemphigus vulgaris, but this is actually twice as common as that condition. It typically affects patients 50 to 60 years old and has a 2-to-1 female predilection. Clinically, this can affect any mucosal surface and occasionally affects the skin. The most common clinical sign of this condition is desquamative gingivitis, or peeling of the gingival tissue. We can also see diffuse erythematous gingiva like our patient, as well as blisters that can rupture to form ulcerations. The most significant or serious aspect of this condition is what this question is actually asking about. When it spreads to this area, it can be very concerning and often requires a specific referral to treat. And that area would be A, the conjunctiva, or the mucous membrane that covers the front of the eye and lines the inside of the eyelids. This ocular involvement can lead to blindness. The way it works is that scarring of the conjunctiva obstructs the orifices of glands that produce tears, and this results in a dry eye, which causes keratinization of the corneal epithelium. So as you can see from this image, you're starting to get scarring over of this conjunctiva, and it can cause blindness. It's very concerning. So a patient with this condition must be referred to an ophthalmologist. Now, to confirm the diagnosis for mucous membrane pemphigoid, a biopsy can be done to examine the histopathology. The histopathology for this condition would show separation of the epithelial layer from the underlying connective tissue at the basement membrane zone, and this is due to the loss of hemidesmosome proteins. Now, although we know that the answer for this question is the conjunctiva, let's go through the other answer choices and talk about why these are not possible areas of spread for this condition. And we'll start with the scalp. Now, although blistering and scarring can be seen on cutaneous surfaces in mucous membrane pemphigoid, involvement for this condition is not a concern on the scalp. It's also much more frequent to see symptoms on mucous membrane than the skin overall, as the name implies, so this would not be the correct answer. Next, we have the peritoneal cavity. And if you didn't remember what the peritoneal cavity is, it's the space within the abdomen that contains organs like the stomach and the liver. It is lined by a membrane known as the peritoneum, but it's lined by a serous membrane and not a mucous membrane. The difference between the two is that mucous membranes line the body passageways that are exposed to the outside environment, while serous membranes line internal body cavities that are not exposed to the external environment. So mucous membranes are called mucous membranes because they have to secrete mucus for protection and hydration from the outside environment. So since this answer choice is an internal cavity lined by a serous membrane, mucous membrane pemphigoid would not spread to this area. And then lastly, we have the pericardium. Now, this is a very similar answer to the peritoneal cavity. The pericardium is a fluid-filled sac that contains the heart. Once again, this line's an internal body cavity and is therefore a serous membrane. Because it's not a mucous membrane pemphigoid would not affect it. For reference, other mucous membranes of the body include the mouth, obviously, but also the inside of the nose and the ears. So in this case, this patient has mucous membrane pemphigoid based off the generalized gingival erythema and the small ruptured gingival blisters. And a big concern for this condition is it's spreading to the conjunctiva, and this would definitely require a referral to an ophthalmologist to prevent blindness in the patient.